Welcome everyone back to Einstein's Eyes. We're thrilled to have you. I'm Carl Rosen, oculoplastics, also fellowship in neuro-ophthalmology in Anchorage, Alaska at Ophthalmic Associates. I'd like to introduce my partner, Jon Ditkoff. Jon?
Hey, nice to see everybody. So my practice, I do general ophthalmology, specialize in cornea in northern New Jersey. Today I'm coming from Manhattan, which is nice, a little change of pace, but my practice is in northern New Jersey.
Right. And so the connection with Jon and I is that we were both residents at Albert Einstein College of Medicine during our ophthalmology residency. And then we went on to do fellowships. But we are thrilled today to have Robin Grendahl, a pediatric ophthalmologist in Anchorage, Alaska. Robin and I have been working together for many years. Robin, now correct me if I'm wrong, Robin, but I think I got this. So you trained at University of Washington School of Medicine.
That's right.
Did your ophthalmology residency there, and then went on to Wills Eye Hospital to do pediatric ophthalmology fellowship.
Right, that's right. So a year at Wills Eye Hospital in Philadelphia, and then I returned to my hometown of Anchorage, Alaska. So greetings from Alaska.
That explains it.
Yeah, right.
Grew up
fantastic.
Here.
So, so today we are christening pediatric ophthalmology on the channel with Robin, and we're really looking forward to hearing about esotropia. We won't touch on every aspect of esotropia, but this is our major topic today, and I'm going to let Robin run with this.
Great. Well, I'm excited to be a part of this and honored that you asked me to do the first presentation in pediatric ophthalmology. But today I'm going to be talking about childhood esotropias. And esotropia is a form of strabismus in which one or both eyes is turning into the nose. So in effect, it's an ocular misalignment. And so this is very important in childhood, and we'll kind of touch on some of those concerns that can develop if a child develops esotropia. Now, I'd like to discuss this from the perspective of what a parent might experience. So I'll kind of keep that in mind, but also remind everyone that esotropia can occur at any age. So we can have a child born who looks esotropic, and we can also have a patient present at very advanced ages with new onset esotropia.
Robin,
yes.
Can I show this?
Sure.
So let me share this with you. So,
oh, sure.
So here we are.
Right. Yeah. So this is a picture of a child with esotropia, and you can see in this picture that it might be kind of hard to understand which eye the child is fixing with. And that's not uncommon. It's sort of confusing for some parents. So it appears probably in this picture, the child is fixing with their left eye and the right eye is turning into the nose. And so it's very common where parents or even primary care doctors aren't sure which eye is turning in. And that's where we come in and we help people sort out what's going on with these kiddos. So I think in order to understand esotropia, I think we should just say a few words about early childhood eye development, especially in early infancy and in the neonate. And so when a child is born, their vision is not like ours. They see shapes and forms, and they really are not looking across the room, and they don't share our vision. So there's a lot of development that happens in the first 4 months of life. And so during this period, there can often be quite kind of a play in ocular misalignment, meaning sometimes the eyes look turned in, sometimes they look turned out. And so the parents aren't really sure what's going on. And so I usually recommend that when parents see this in the first 4 months of life, don't get too worried because it could go away, but consult with the pediatrician at the next well child check to determine if this is in fact a problem. Sometimes the pediatricians will send the child to us at this early age, and usually this goes away by about 4 months of age. So that is something that parents can see. And that kind of leads us into the next type of esotropia I'd like to discuss, which is kind of shown in this picture right here. I'd like to discuss infantile esotropia. And this is a situation when that early neonatal esotropia doesn't resolve and the child has a fairly constant large angle crossing of the eyes, as you can see in this picture. So sometimes one eye will turn in and sometimes both eyes will. The child will alternate between using either eye, and it can be kind of confusing for everyone trying to evaluate. The thing that I remind parents, residents, and medical students is this is usually the type of esotropia that you can see from across the room. You can spot it. It's usually not subtle. And sometimes parents will even come up, tell me that they go to a grocery store and strangers will come up to them and say, hey, do you know your child's eye is crossing? And so this is usually not subtle. And usually what we do for these children is we do a very thorough eye exam, and we want to make sure that they don't have any other pathology going on to cause the eyes to cross, such as a malformation of the eye, or sometimes very rarely an intraocular tumor known as retinoblastoma. And once we've ruled out those things and the child is still showing us this very large angle, constant crossing of the eyes, then the next treatment is usually surgical. And usually with this form of esotropia, we weaken the inside muscles that are pulling the eyes into the nose, and it is very effective. So that's really that's infantile esotropia. And that is, we see that quite a bit, but it's not as common as the next type of esotropia that I'd like to discuss. And so let's go back, let's go a little later in the child's development. And then we have a child typically who's around 18 months to 2.5 years of age. And the family will start to see the eyes crossing very intermittently and sporadically. So sometimes the parents will see that one eye crossing when they're very tired, and then the next day it's gone. And so the parents are really hoping that this will go away. One of the things that I tell families is watch your child at the dinner table when they're sitting in their high chair. They might be, at this age, they might be looking down at their tray, pick up a Cheerio, put it in their mouth, and they look up at you, and one eye is really turning into the nose. And so what that tells me is the child is focusing on something at near, and that's driving the eye to cross. And so this is known most commonly as accommodative esotropia. And we can probably show the next picture of this for folks to view.
Good.
So when I see a child this age, the first thing I think of is, do they need glasses? And let's back up just a little bit and remind people who might not know that most children are in fact farsighted or hyperopic. That's a term to describe the refractive state of most children's eyes. And we usually don't get too worried about it unless they start going cross-eyed or if it's above a certain threshold. So having said that, most of these children with accommodative esotropia are in fact moderately farsighted or have high farsightedness, and it can be very asymmetric between the two eyes. So one of the first things I do is check these kiddos for glasses. And what we find is they have moderate farsightedness, also known as hyperopia, or they can have high farsightedness. So I then will prescribe these kiddos glasses. And this slide here, this picture demonstrates a child with a left eye turning into the nose. You can see that they're fixing with the right eye. The left eye is crossing. There's no glasses. And then we get the kiddo their hyperopic correction. They put their glasses on, and almost like magic, the eyes straighten out and the child is looking at you with well-aligned eyes. So this is a very treatable condition. However, we like to catch these kids very early in the course of their esotropia. We like to treat them well before the eye permanently starts to turn into the nose. And one of the biggest reasons for that is if we let a child's eye deviate into the nose for prolonged periods, they will in fact stop paying attention to the eye, they'll stop using it, and they'll develop something called amblyopia. So that is abnormal visual development at the level of the brain that doesn't allow the child to use that eye, and the vision can be very poor or often legally blind. So when a child has the accommodative esotropia with the eye crossing and the amblyopia, we then will patch the aligned eye, the better seeing eye, with an occluder, like a little bandage type occluder underneath the glasses to force them to use the fellow eye. And in this way, we treat the poor vision in the affected eye. And, sometimes it can take months to rehabilitate the vision, but if we can get these kids young enough, we have a really good opportunity to intervene.
Perfect.
So,
Perfect.
yeah.
Yeah, Robin, that was fantastic.
Wonderful.
Jon, anything you want to add?
Yeah, so a couple of things. Pseudoesotropia
Sure.
For me, as a general ophthalmologist, it's probably more common than the condom over the infantile, where I mean, you could describe it, but many parents will come in saying it looks like my child's eye is crossing, but we can tell very quickly that it's not just by doing a light test. But I mean, you can expound on that.
Right, right. No, in fact, pseudoesotropia is extremely common. It's far more common than true congenital or infantile esotropia. And so many children in the early stages of development have a broader nasal bridge between the two eyes, and they often have an extra little fold of skin over the inner corner of the eye. And so that, in fact, hides some of the white of the eye and gives this optical illusion, if you will, that the eyes are turning in. And so that sometimes is really hard for parents to sort out. It's hard for pediatricians and some general ophthalmologists to sort out as well. Whenever the child looks off to the side, more of the white is covered in one eye, and this gives the illusion of the child being cross-eyed. So parents will often bring in pictures for me. I'll do a cell phone biopsy. I'll take a look what they're worried about, and hopefully I can allay their fears if in fact this is what's going on. And then parents, just go ahead.
What I've done is I've actually told parents, like, just take out a flashlight and shine it, or like a little light. And if you see that the light is right in the center of the pupil, you're good. Whereas
Absolutely.
in true esotropia, it won't be. It'll be out to the side. So that, like, you empower them. I like doing that.
Absolutely. And I think this picture here demonstrates just what you're talking about. This light reflex here is in one spot, and then it's in a relatively different spot on the eye. And that is, and sometimes parents come in and they are convinced their child's eye is crossing. And I always I like to teach them and show them so that they know what to look for. And so I can say, okay, look at this child, the cornea light reflex is nice and centered, and we're in good shape. So having said that, though, sometimes esotropia, when it first starts, is very intermittent. And so I have seen kids before where they come in and I think, oh my goodness, this is just pseudoesotropia. And I reassure everybody. And then I say, just to make sure, let's see you back in about 3 months and see what's going on for just a quick alignment check if I'm at all worried. And sometimes they'll come back and lo and behold, they'll show true turning in of the eye, esotropia, and then we go ahead and treat it. So yeah.
That's good information for me.
Yeah, that's great. So, so Robin, thank you so much. I think this helps our audience and certainly elevates our game at Einstein's Eyes. And
now we got to do exotropia. We got to do all the procedures.
Right. So Robin,
it's endless. There's so much.
Right. I'm going to invite you back, Robin. You know you're going to get that invitation.
All right. Looking forward to it.
All right. Hope everybody likes it. Thank you, everyone. We'll see you on the next video.